there's an intrusive thought, if I don't put my socks on right, my mom's going to die in a car accident tomorrow. Change the socks, okay, anxiety goes down. And then, well, what if it brushed against my foot? Better do it again, right? So it's this constant up and down anxiety.
You're going to want to go and, let's say, wash your hands as a result of this, and give it 2 hours. Keep rating yourself during that time. And what inevitably happens is the rating is sky high for how bad they're feeling, how anxious they're feeling, and it falls off. And it never lasts for 2 hours. We say at the end of 2 hours, if it's still there, go ahead and wash. And you do this the first time, and whatever I said, this was a 70. And the next time you do it, it's a 60. And the fourth time you do it, it's a 40. And then eventually you find out you can do it and there's no problem at all. And so the mastery that people can get by doing this is fantastic. And people then learn the skill. Without treatment, unfortunately, OCD tends to be pretty much a lifelong disorder. With the skills you gain in learning how to master it, if there is an exacerbation for whatever reason down the road, you know now how to go about tackling this. The group that Lauren alluded to was incredibly powerful because one person might be a contamination person, and the next person in the group is a checker where they would have to go and check all the appliances before going to bed and the door and all the rest. And that checker would say to the contamination, oh, come on now, that's no big deal. I can do that. You can too. And the contamination person would say to the checker, oh, come on, you know, the stove's not going to catch fire overnight. And so they were incredibly helpful to one another in going through this. I get all excited talking about this because it's too much fun.
Me too. I cut myself off.
We know with bipolar disorders, when we see it on a graph, we see something going up and then it's going down. In depression, it's usually just a down. In panic attacks, we see, as we saw, it gets you mid-run and then it disappears. In OCD, how does it look usually?
I'd say OCD looks like this the entire day, where there's an intrusive thought. If I don't put my socks on right, my mom's going to die in a car accident tomorrow. Change the socks, okay, anxiety goes down. And then, well, what if it brushed against my foot? Better do it again, right? So it's this constant up and down anxiety. And depression is often a secondary disorder to OCD. So folks with OCD usually also have some amount of depression, which is making motivation hard, which makes treatment hard. And yeah, it's a rough combo.
You're leading into the question of what's the role for meds. So remember I talked about the Yale-Brown Obsessive Compulsive Scale. That gives you basically 20 points for obsessions, 20 points for compulsions, a maximum of 40. In most of the studies with meds alone, people start out around 25, and with meds they get down to maybe 18 to 20. That's a whole lot better, but that's still pretty significantly impaired. The other problem is if you're on meds and you stop them, the chances of the OCD reemerging are very high. On the other hand, if you've been doing ERP or similar treatment, you can always come back to it. ERP, to my knowledge, has never caused anorgasmia. Medications have. The side effects are really a whole lot better with behavioral treatment. On the other hand, if you are significantly depressed, and the comorbidity for depression and OCD is quite real, it's going to be really hard to do the behavioral work. So if it was me, I would usually start with behavioral therapy. If it was not fully successful, I would do meds in addition. Or if I was so depressed that I couldn't really engage in behavioral treatment, I would clearly start with an antidepressant, and one of the kinds of antidepressants that work with OCD, and then hopefully be able to engage successfully with the psychological treatment.
Yeah, that's similar to our process. We always try the therapy first. We give it 3 to 4 months, which is the industry standard with the research. And then if the person isn't making gains, we say, all right, let's talk about a med consult. And they might say, I don't want to be on meds for the rest of my life. And the good news with OCD and some anxiety disorders is you might not have to be, right? It sometimes is just 10% of space that they get in their brain that helps gain the new skills and helps get the motivation to start moving. So it could be a short-term way to access the therapy, which then can take over from there depending on the case.
Hi. Is there any relation with, and I might not be pronouncing it right, okay, anxiety, OCD, what about agoraphobia?
Agoraphobia?
That's it.
Yeah, so agoraphobia, for those that don't know, is a fear of going into a public space and having a panic attack. Usually people think agoraphobia is a fear of leaving the house, but what it is at its root is a fear of having an uncontrollable physical thing happen or losing control in a situation that you can't escape or in public where it would be embarrassing. So agoraphobia is another type of anxiety disorder, so they are very related in that way. And the treatment would be similar. There aren't rituals with agoraphobia, but there are safety behaviors. A safety behavior might be having someone on the phone the whole time you're out of the house, just in case something happens, so that they can help you or guide you through it. It might mean always sitting in the front seat of the bus, so that if something happened, you could get off quickly without being embarrassed. So with agoraphobia, we would do exposure therapy too, where if the person was stuck in their house, because that's when it's at its worst, that's what it looks like, we might say, okay, the first step of the hierarchy is to walk outside for 2 minutes and then go back in the house. Next week, we work on walking around the block. The next week, we go in the car, sit in it. Next week, we drive around the block, and so on and so forth. So very similar treatment. Exposure works for both.
So agoraphobia almost always comes associated with panic disorder. Absolutely agree that for the agoraphobia, clearly what you need to do is in vivo desensitization kind of work, where again we have people do this graduated sort of approach. The panic attacks are quite responsive to meds if you can get people to do it. So people with panic disorder are incredibly tuned into every bodily twinge and very aware of everything that's happening in their body. So whenever I would work with a patient, I would quote a study where patients were randomized to either an antidepressant or a placebo, and over half the patients were unable to tolerate placebo due to toxicity. So think about what happens. You know, again, you are so aware of everything that's happening in your body and so scared by what it means that you have the kind of thing that all of us experience. Oh my God, my toe hurts. And we'll associate that inevitably with the med. So getting people to take meds who have panic disorder takes a lot of education, and you get there. But, you know, you've got two fundamental kinds of anxiety you're dealing with. You've got the panic attacks themselves, and you've got anticipatory anxiety. You have the anxiety of, again, if I get in the line at Wegmans at the checkout counter, it could happen then, and there's not going to be a good way to leave. What you find is a lot of people who shop at 2 in the morning, because there won't be a line, who have full-blown panic disorder and agoraphobia. And so again, this sort of graduated approach, go sit on the porch, try going to the corner mailbox. this graduated sort of approach can be remarkably helpful, and again, people can really do very well with this.
Yeah, just piggybacking off of that, because I love treating panic disorder too, because you can actually treat panic in one session in some cases. There's actually a treatment that they just studied in Norway where it was extremely effective. They did the same 90-minute session over and over until the person got better, and usually it took anywhere from 1 to 3 sessions. What it really takes from a behavioral standpoint is psychoeducation. Typically, panic attacks are about fearing physical sensations that are happening. So right now, my heart could start beating faster than it should while I'm sitting down, and I might think, okay, why is my heart racing as if there was a saber-toothed tiger in the room? I look around, no tiger, no fire, must be something wrong with my body. So the body becomes the threat. So with panic, we can also treat it really effectively by practicing having these physical sensations on purpose. So it could be spinning in a chair in the office to feel dizzy on purpose, and then to sit with that feeling and let the anxiety go up and come down.
Around.
A chair that spins around,
Right.
Yes. Not this chair. We might do things like jumping jacks and then sitting down and just feeling a heart racing while you're sitting. Practicing these feelings can ultimately reduce symptoms. And I always say the best way to not have a panic attack is to try to have a panic attack. Because if we try to have one, if we really want to have one, it's almost impossible for it to happen, because the whole reason it cascades is because we don't want to have these sensations. They feel dangerous and bad, and we're trying to stop them, which is then feeding the anxiety.
40 plus years ago, I was at NIMH, and we were doing a lot of panic disorder work. And I had this incredible patient who had literally not left her apartment for 25 years. Had managed to somehow, by finding a series of men who in exchange for sex were doing her laundry and bringing her food. And incredibly courageously, she comes in for a study. And we did, it was, I can't remember which antidepressant, I think imipramine versus placebo. And we were doing classic in vivo desensitization work where she's going out into the community. We would have her go out initially with one of the nurses on the unit, and then she would do these things on her own. She made great strides. We were doing, it was something called studying lactate infusions that you could give to people with panic disorder, and reliably within the first 10 minutes they would experience a full-blown panic attack. People without panic disorder wouldn't. She had the classic reaction. She does incredibly well. So well, in fact, that the last step in Washington, for those of you who've been there, there is a subway stop where you've got to go up like several hundred feet in the escalator in order to get out. So, you know, anybody could do that, could manage anything. It gets that last one. The nurse who's been working with her says, "Larry, I'm sorry, I can't go to that stop. You're going to need to get somebody else." She manages this successfully. Meanwhile, she's got every side effect known to man, and it's clear she's on the active drug and not a placebo. We give her another lactate infusion. She sails through it. She's fine. This woman has made this incredible turnaround. We then break the blind and discover she's been on placebo the entire time. I would get Christmas cards from her for the next 20 years, and she continued to do really well. A great success story.
Thank you. You talk about behavioral therapy for panic attacks and OCD. What about anxiety and depression?
Yes, also works. So with anxiety, we would probably want to categorize what type of anxiety. If someone's been told they just have anxiety, it might be generalized anxiety disorder or panic. So at our clinic, we always start with a full diagnostic assessment to figure out exactly what type of anxiety are we talking about, so that we know how to treat it best. But generally speaking, cognitive behavioral therapy, CBT, has skills like cognitive restructuring, which work really well for anxiety, regardless of the topic, except I wouldn't really use it for OCD, and behavioral activation, which is one of the best behavioral treatments for depression. Yeah.
Back to something I was thinking back to the ERP stuff is how often or at all, if it happens at all, do you have OCD, patients with OCD who have compulsions that are, I guess I don't know how to say, like complex and difficult to replicate, like in like the controlled environment that you're trying to like start out in, and like what is your approach? I guess I don't know if that makes sense, but
I think it does. And if we don't answer it well, feel free to ask a clarifying question. But typically what we do is we do the initial assessment and then figure out if it makes the most sense for the person to come into the office, for us to go to them, or to do it via telehealth. So that so far we've been able to, in all cases, figure out a way to be in the real moment with the person. Oftentimes the most complex compulsions, especially if they're visible, are at home, for the reasons the person on in the movie was discussing, because it can be embarrassing to do things in public, and folks with OCD are extremely capable and talented at hiding compulsions for reasons of stigma and social anxiety and fear of being seen as weird. So there can be very complex ones at home. I'd say the hardest ones to treat are actually mental compulsions for many therapists, because they can't see them. So it can feel confusing of how do you resist something that's invisible. It can be confusing for therapists and patients if it's not putting on and off a sock. It can be harder to track, but we know that the skills work. There was a long time misconception that mental compulsions were totally different. They would call that pure OCD, pure obsession, as if there weren't compulsions, but they're very treatable.
I'm going to jump off of that into a vague, tangentially related thing. The impact on families is huge. There's somebody you love. So I had a patient who would have this aggressive thought that he was about to knife his granddaughter, who he very much loved. So it was impossible to be at a meal where a knife might be present, for instance. And then every time he would have this thought, he would turn to his wife and say, "I'm not going to do this, am I?" And she would say, "No, you're not." And that had become then the compulsive behavior, this look to her for reassurance. She loved him. It worked for 15 seconds, but he would feel better. So often you end up needing to treat the whole family, and to get her to stop offering the reassurance as part of the treatment. No, dear, this is your obsession, as opposed to offering the reassurance. So this sort of echoes out.
This is a comment from the virtual audience. Hi, Damon from the film here. I have felt that after 8 months of a new med for bipolar, I have felt my OCD as milder than before. As an example, the shoes and socks routine has become easier.
I was missing the question. You get it?
Nice. I think
it's just a comment.
it was a comment from Damon saying that once his bipolar was treated with meds, his OCD obsessions decreased. Is that right? Yeah, that makes sense.
Yeah, no, and absolutely it can happen. When I talked about the going from 25 to 18 to 20, that's the average. And certainly you're going to see people who have glorious responses. I had another patient who, a nurse, and she had contamination obsessions. And again, talk about the family impact. She made her kids and her husband would have to change the minute they walked in the door so their contaminated street clothes would not come into the house. Now, this is a trained nurse who knew this didn't make sense. And she was one of those glorious responders to meds, but also had lots of side effects, and so periodically she would stop. And I got a call from her at one point when she described, I just washed the dog when he came back into the house, and I realized I need to go back on, and it's worth it in terms of the side effects. On it, she was completely asymptomatic.
And with his bipolar disorder being treated effectively with meds, wouldn't it make sense that
bipolar,
his
okay. Missed that.
he would have maybe less sticky negative thoughts, maybe less fast super speed intrusive thoughts when manic?
Absolutely, yeah. I'm sorry, I missed the bipolar part. No, and clearly there, meds can make a humongous difference as opposed to OCD, where it tends to be more muted.
I didn't realize Damon was listening, and maybe he
Hi,
still
Damon.
is. But great film. we didn't talk much about the film itself, but thank you so much for making it, and I'm sure it was a challenge at times, but it was very enjoyable and very enlightening too. So thanks.
Yeah, I thought the film did a great job at showing that insight can be so high in OCD, and often is, that the person can be aware that this is totally ridiculous and feel like I have to do this and it's life or death. And I thought they also did a great job of tying in humor, which can be such a powerful mechanism of change and treatment.
Sorry, just really quick. I guess a clarifying question was like, are there certain mental compulsions that are like you find common, like an example of a mental compulsion that you see a lot?
Sure. So a mental compulsion would be like if I, well, it could be anything, but say I'm having a thought, an intrusive thought comes in from OCD that says, your sister is going to die of cancer. Then I could do a mental compulsion that could just say, clear, 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 like something that could just be clearing out the thought. I could have a mental compulsion that is saying stop. I could have a mental compulsion that's saying, reassuring myself that she's okay, like she's got a good bill of health. So it could also be counting to 7, 1, 2, 3, 4, 5, 6, 7, 7, 6, 6, 5, 4, 3, 2, 1. It doesn't have to be totally linked to the content, but the main thing is that it has to be a repeated mental act that reduces the anxiety. It's the only rule.
I know it's getting a little late, so if this is a longer answer, but is the issue of hoarding part of an OCD, or where does that fit? I know it's sometimes discussed separately, and years ago there was a great Real Mind film on exactly that issue, but if there's a little bit of time, just some clarification on where that fits?
So with DSM-5, hoarding, up until then, had been considered a variant of OCD. What was striking was that it was far and away the least treatment responsive variant. Moreover, there's a stark difference that people with OCD almost always preserve insight, and people with hoarding almost never do. So with DSM-5, there was a decision to move it away into its own separate category. Our treatment for it, by comparison, is really pretty bad. We are much more successful with OCD than we are with hoarding disorder. The treatments for hoarding that have worked are really public health measures that the two most successful programs I know are in San Francisco and Boston, both places with remarkably high rents, where the public housing folks have figured out that it costs us some ridiculous amount of money to evict somebody, but they've got to go because of the health risk they pose, of risk of fire, risk of rodents, risk of all kinds of things. And they then hire or have trained people to go in to the individual's house, item by item, going over what to do. So that sort of public health approach works. Psychotherapy has not worked, to my knowledge, unless you've got some new breakthrough.
Yeah, cognitive behavioral therapy can work with exposure. So Randy Frost's model of, but it is the same, going item by item.
Yep.
And instead of just making a decision item by item, it's understanding the relationship to stuff, and that can shift over time. So I've worked with folks over, it takes a long time, over the course of a year, going from a house that's full from floor to ceiling, 7 bedrooms, to a very livable space. And it does get faster, but it is slow. And there are many cases where there's no insight or interest in change, so that is a different story. But there are many folks that do want to be able to use their kitchen and can benefit from CBT with exposure. But it does require hands-on in the house. Oh, can I just say one last thing?
Please.
About accessing treatment? Exposure therapy is one of the most feared treatments by therapists. So if you are recommending exposure therapy to someone, just make sure that they're going to a therapist that advertise that as what they do, or him, because most therapists might say they do CBT, but not be willing to or knowledgeable on exposure therapy. So just wanted to put that out there, that it's important to do your research and find someone that does speak about doing this work, not just saying they do CBT generally.
And should they want to contact Genesee Valley, how would they do that?
Well, if you Google Genesee Valley Psychology, it will show up, and we'd love to have folks. We have OCD track, PTSD, trauma track, and dialectic behavior therapy, DBT.
So speaking of that, the next meeting of the congregation will be next Tuesday, and a film about PTSD. So please come on back. Thank you all so much.